Hello everyone, welcome to this seminar in which we are going to use ultrasound to enhance or to augment the clinical exam and how to use it in different clinical scenarios. Before starting, we need to take in mind a couple of technical considerations. Every time you scan a patient or you scan a model into a transversal, we need to put the probe marker towards the patient's right. If we are going to scan in a longitudinal or sagittal view, we need to place the probe marker towards the patient's head. The first thing we need to know before scanning patients are abnormal lesions that you have to take in mind always. First of all, the cyst. The cysts are fluid-filled round structures inside mainly solid organs. The image in ultrasound is really characteristic and is anechoic because all the cysts are full of fluid with the posterior acoustic enhancement typical from fluid structures. Like in this view, which you are actually seeing a kidney, and in the differentiation between cortex and medulla, there's a round anechoic structure. This is a cyst. The cyst can be so big, as you can evaluate in this clip again. And how to distinguish? You are actually looking at a cyst instead of a vessel in a long axis, in a short axis, because they have no flow inside. There's no Doppler, no color signal inside a cyst, and a vessel is supposed to have both. Take a look again, because if you find a cyst, it's really common to find into the surrounding organs. For example, if you find a cyst in the right kidney, take a look at the liver, because the probability of having cyst is higher than normal. The second structure we can evaluate during exam is lithiasis. They're actually stones. They're not so stone-like, but real stones inside mainly excretory organs. The characteristics in terms of ultrasound imaging of lithiasis is really simple as well. They're a hyperechoic with a posterior acoustic shadowing. Like in this case, we are evaluating a stone-like structure inside a bladder. And in the second clip, we are evaluating lithiasis inside the gallbladder. We can evaluate as well stone-like structures inside solid organs, but these will be calcifications instead of lithiasis. Another structure we can evaluate, which is can be normal or not, are the masses. Masses are tissue-like structures inside mainly as well solid organs. The masses can have all ranges of echogenicity. Like in this example, we are evaluating an hypoechoic mass inside the thyroid left lobe. This is a mass as well, which is kind of isoechoic inside the bladder. And we have a mass here in this image, which is hyperechoic. It's inside the liver. And there's a mirror artifact associated to this image, in which we are evaluating like two structures, but the second one, which is above the diaphragm, is just an artifact. The first anatomical structure we are evaluating today is the thyroid gland. The anatomy is really simple, because we are evaluating two lateral lobes connected through an isthmus, and about 50% of normal population has an extra pyramidal lobe. The size, it's about 5 to 6 centimeters per each lobe in a long axis. The classical way to examine the thyroid gland is by pure palpation. We have to come from behind of the patient, and we have to use both hands, especially the fingers, to palpate and evaluate the size. So if the size is normal or not, in terms of if the gland is enlarged or not, and masses as well. Before scanning, we need to select the probe. And the thyroid is a really superficial structure, so our probe will be the linear probe. We need to adjust the parameters in terms of gain and depth, as always. And the orientation for the thyroid gland should be both longitudinal and transverse. Under an ultrasound point of view, we are evaluating the size. We have to measure the size. We have to measure the size of each lobe. We are assessing the echogenicity because the goiter, which is the enlargement, abnormal enlargement of the gland, is associated to non-isoechogenic gland. So the heterogeneity is associated to an abnormal gland. We can, from time to time, assess masses from solid to fluid. Especially the fluid masses are really common to be found in a thyroid gland, and most of them are cysts. The second structure we are going to evaluate is the liver. The liver, for us, is a solid organ inside the thorax, the theoretical thorax, and is composed by two main lobes. The classical way to examine the liver is through palpation plus minus percussion, and we are assessing mainly the size, so we can assess the enlargement of the liver, and we are assessing the edges. Our classical examination includes the determination or the detection of masses, but it can be really difficult and challenging. So before scanning, we need to select the probe. And for this, for assessing the liver, we are using the curvilinear probe. As well, adjust parameters, especially gain and depth. And the orientation. For the liver left lobe, we are going to orientate the probe into a long and transversal view. But for assessing the right lobe, it's much better an oblique approach. The normal liver. The normal liver is smooth in terms of echogenicity. There are a lot of vessels inside. One of them have a classical hyperechoic wall, like a white wall round. Another don't. And there are another structures inside the liver, which are the gallbladder and the diaphragm, which are actually a border between abdomen and thorax. For the left lobe, we are going to transversal or a pure longitudinal way. And for the right lobe, we are much better if we use the oblique approach and fanning up and down to see the whole right side of the liver. The size. We can assess the size, we can measure the size, and we can assess the hepatomegaly, which is the abnormal enlargement of the liver, by indirect signs. If you need to measure, the magical figures are less than 15 centimeters for the right lobe and less than 5 centimeters for the left lobe. As well, we can go to the indirect signs, like in these two clips, because the indirect signs are in a normal liver, all the free edges forms acute angles, and the liver tip does not overpass the right kidney. There are some kinds of tips and tricks to assess properly the liver, and one of them is deep breathing. Actually, the liver is inside the theoretical thorax, so if you ask the patient for deep breathing, everything from the diaphragm will be down, so it will be easier to evaluate. If possible, your patient should be fasting, but I know that in clinical scenarios it's really tough. And the ultrasound beam, you have to point towards below the ribs. What is the hepatomegaly? Hepatomegaly, it's an abnormal enlargement of the liver. And like in this view, we are evaluating the indirect signs. So the liver does not form an acute angle. It's like a round structure. It's not a sharp edge. and the inferior tip of the liver is actually overpassing the level of the right kidney in both clips, in both pictures. There's another cause of hepatomegaly, which is the congestive, in which we are assessing some normal or normalish liver, but a lot of congestion in terms of the hepatic veins. The hepatic veins are really enlarged. The second condition we are assessing while evaluating the liver is the steatosis, or the fatty liver, is in which the fat is inside the parenchyma is like spotted by fat. So we need to compare first the echogenicity with the kidney cortex. Normally, the cortex and the liver has almost the same homogeneity. In the steatosis, the echogenicity of the liver is higher, much higher than normal. If the steatosis increases, the more steatosis, the less penetration of the bean. So it means that you will be able to see even worse with the more degree of steatosis. Remember that steatosis can occur with or without hepatomegaly. The cirrhosis inside the liver implies a decreasement in the function of AORTA. So, and we are substituting in the cirrhosis the normal liver parenchyma for a fibroid tissue. So the ultrasound appearance will be irregular, with irregular surface, with irregular edges. The echogenicity would be abnormal as well, in terms not being smooth. And there are a couple of things associated to the cirrhosis. One of them is the ascites, like you can see around the liver here. And the second is are masses, especially liver cancer associated to the cirrhosis, like you can evaluate in this clip in the liver tip. Biliary. We are more sensitive than clinical exam to assess the gallbladder. The gallbladder is supposed to be in the inferior side of the liver, attached to the falciform ligament in its inferior side. The classical way to examine the gallbladder is by pure palpation. And there's a Murphy sign in which we are evaluating the inflammation of the gallbladder. For assessing the gallbladder, it's much better to use an oblique approach and fanning up and down till we identify this full fluid structure. Tips and tricks like for assessing the liver, deep breathing, this is really important, fasting if possible as well, and again the ultrasound being below the ribs. The size of the gallbladder depends on the fasting. So the more fasting, the bigger gallbladder. We need to measure the wall to assess the inflammation. In a normal gallbladder has the anterior wall, which measures less than 3 millimeters. First thing we can evaluate in a non-normal gallbladder: stones. Stones can be just one or can be multiple. The stones are hyperechoic structures with a posterior shadowing. And the second condition we can evaluate better with ultrasound and compare with our clinical exam, classical clinical exam, is the inflammation of the gallbladder, which is the cholecystitis. For the cholecystitis in our environment, we need the presence of stone, at least one. The inflammation is defined by the enlargement or the thickening of the gallbladder wall greater than 3 millimeters, and we can evaluate as well the sonographic Murphy sign, which is supposed to be more sensitive than a clinical sonographic, but the clinical Murphy sign, in which we are placing the gallbladder in the middle of the screen and just press to cause the characteristic pain in our patient. Renal. We can evaluate the kidneys with ultrasound, In the anatomy, we need to take in mind is that both kidneys are posterior, so both kidneys are in the retroperitoneal space. The long axis is plus minus 12 centimeters, 10 to 12. And the transverse axis of the both kidneys is plus minus 6 centimeters. The classical way to examine the kidneys is by manual palpation. In some textbooks, we can evaluate or we can read the percussion as a tool for assessing the kidneys as well, but it's really tough and difficult to assess them with just this technique. So before scanning, we need to, again, select the probe, and the probe would be the curvilinear as well. Parameters to gain and depth, and we need to place our probe in the kidney's long exam. Remember where the kidneys are, and the right kidney is supposed to be below the mid-axillary line, and the left kidney is more posterior and superior than the right kidney, so it's supposed to be below the posterior axillary line, a little bit higher in terms of superior than the right kidney. The ultrasound appearance of a kidney is really characteristic, in which we can distinguish the cortex versus the medulla. The cortex is more hypoechoic and the medulla is supposed to be hyperechoic. There are some black structures inside. There are mainly vessels. So to be sure that the black structures we are evaluating are vessels, we can place the Doppler or the color inside them. Tips and tricks. If the patient can be lateral decubitus, will be easier. But in general, if you find the place in which you are supposed to see the kidney and you see nothing, one of the tricks is going more posterior. Abnormal situations evaluated by ultrasound, and one is the hydronephrosis, which is the dilation of the calyces and the collective system with secondary compression of the kidney, of the parenchyma. That can be mild, like in this case, moderate, or severe. The clinical relevance for them are moderate and severe, because mild can occur even in physiological situations. We can assess the size as well. Like in this case, we are evaluating a real small kidney that can give us an idea of the course in terms of time of the condition. If the patient has something which is acute, or like in this case, is really chronic. The bladder. There's one situation in which ultrasound is a game changer. It is the urinary retention. Remember that the bladder, it's an infraperitoneal and full fluid structure. And for evaluating the urinary retention, that in some cases can be really challenging, we have to use the palpation. So we have to determine the level of the bladder distension above the symphysis, and we need to know that using just a Foley to assess whether the patient has or not, a urinary retention should never be part of our daily practice. For assessing the bladder, we can go from the transverse view to the long or sagittal view, and before scanning we need to select the probe, which is the curvilinear as well. Take in mind that you need to decrease the gain because you are evaluating a full structure which is full of fluid. So you are supposed to evaluate to see a great posterior acoustic enhancement. The orientation, again, transversal and longitudinal. This is the urinary retention. You see a giant structure full of fluid, which is the bladder. Tips and tricks. Remember that the bladder is inside the pelvis. And remember to measure the post-mictional residue. For evaluating what is inside the bladder, the calculation, you have this way to do it. in which we have in the left clip, in the left picture, on a pure transversal view in which we are going to assess the height and weight. In the longitudinal, we need to obtain the third dimension, so the bigger diagonal as possible. So A plus B plus C plus 1/2, 0.5, would be the total volume of the bladder in milliliters. Remember, if the Foley, place a Foley if the patient has more than plus minus 100 milliliters post-mictional tuberosity. Abdominal aorta. Abdominal aorta is really a challenge in our clinical practice because the anatomy is mainly retroperitoneal. The anatomy of the abdominal aorta is going from the epigastrium to the umbilicus, plus minus, and for examine we have a really low accuracy. Because in obese patients we can miss up to 50% of abdominal aortic aneurysms, and in super skinny people we can think that the patient has a AAA, an abdominal aorta aneurysm, but what we are touching, what we are palpating, is the normal and actual aorta. Before scanning, as always, probe selection, the curvilinear probe, and parameters. The main orientation of the aorta should be in a transversal way. From time to time we can go to the longitudinal axis of the aorta to evaluate if we have missed saccular aneurysm. So from proximal to distal, this is the first level. This is the level of epigastrium, in which we are evaluating the aorta and the celiac trunk, with inferior vena cava and the posterior shadowing of the body, vertebral body. This is a little bit inferior, in which we are evaluating the aorta as well, the inferior vena cava with the left renal vein between the superior mesenteric artery and the aorta. On top, we are actually seeing the portal vein and the splenic vein. If we keep on going down, we will evaluate this, which is the iliac bifurcation. What is a AAA? AAA stands for aortic and abdominal aneurysm, and they are supposed to locate likely below the renal bifurcation. So in terms of proximal, medium, or distal, from medium to distal. The definition of a AAA is an aorta with more than 3 centimeters of diameter. We need to measure the aorta and, like in this case, not only the lumen, which is the most black part, most anechoic, but the thrombus, which is around, like a crescent shape, around the lumen. In some cases they are pretty obvious and we don't need to place some color or Doppler to evaluate we are in front of a AAA. But when in doubt, put the Doppler or color to evaluate the typical turbulent flow inside the AAA. If there's something that the ultrasound can super easily evaluate, is the free fluid. And the free fluid can be located in 3 different places. In the peritoneal cavity, which is called ascites, in the pleural space, which is called pleural effusion, and inside the pericardial sac, with the name is pericardial effusion. So let's go to the ascites. The ascites is supposed to collect in most dependent spaces. When we are evaluating a patient in a supine position, the most, like in this case, this fluid should be in these 2 points plus in this 3rd point, which are the most dependent places of the peritoneum. The hepatorenal recess, which is the Morrison spots as well, the splenorenal recess, or the Douglas cul-de-sac. For the classical way to examine the ascites, we have both a combination of palpation and percussion, and this can be challenging again in obese patients. Remember that the transition point between dullness and the tympanic area is supposed to be as well gravity dependent. If we place the patient in a lateral decubitus, the transition point and the dullness and the tympanic area will change. The probe selection, as always in the abdomen, should be the curvilinear probe, and just have to adjust parameters. The orientation, we need to go to the most dependent areas in a patient in a supine position. So we need to go to the long kidneys in with checking the point of the Douglas cul-de-sac in its relationship with the bladder. The location, right upper quadrant, left upper quadrant. So relationship between right kidney and liver and left kidney and spleen. And the pelvis. This is a transverse pelvis with a longitudinal pelvis typical from a male. And this is a pelvis in a transverse way and in a longitudinal way typical from a female. In this case, we are evaluating the uterus, which is anterior in this, which is longitudinal, totally sagittal. This is anterior to the bladder, and we are evaluating both the uterus and the endometrial stripe, which is hyperechoic. Tips and tricks: supine position, especially if you are suspecting really low amounts of fluid. 0 degrees, totally supine position. Don't move the patient because the free fluid will move as well. And this is the ascites, where the ascites looks located in the between right kidney and the liver and the Morrison's patch, or like in this case, which is harder to evaluate, around the spleen. Or like in the third clip, we are actually seeing a small pocket of fluid between the uterus and the rectum, in the Douglas cul-de-sac. Ultrasound is a really powerful way to detect free fluid inside the peritoneum, and it's able to detect ascites less than 250 milliliters. For assessing the pleural effusion is even easier. The anatomy, again, we need to take in mind that the pleural cavity is a virtual space and the fluid will be totally gravity dependent. The classical way to examine pleural effusion is by combination of percussion and auscultation, and we need to determine the level between the dullness and the resonant or tympanic area, both using percussion and auscultation. This image shows us that the location of the pleural effusion is always in the same place, both in a supine position or standing on upright position. The most dependent area of the pleural space is this posterior diaphragmatic recess. So before scanning, we need to select the probe, which is the curvilinear, as always. The parameters, gain and depth. Take in mind, if you are evaluating just small amounts of fluid, we need to decrease the gain to evaluate first and best the free fluid, the pleural effusion. And use the anatomical landmark we know to see where is the fluid located, and even if you are evaluating a small amount of fluid, it should be located above the diaphragm. In terms of location, there's something which is black, anechoic, above the diaphragm, like in this clip, with a lung compression. This image, like floating inside the fluid, is the lung totally compressed by the fluid. The size. We can evaluate really small amounts of fluid, like in this clip, up to 10 milliliters, which is similar in terms of sensitivity to a CT scan. We can evaluate the type as well. If we are able to find a totally black fluid, it should be a trasodate, but it can be from time to time an exudate. But for sure, if you are evaluating and you see this, like not totally black with echoes inside, this for sure should be an exudate. We can assess much better complex effusions, like this septated effusion, or this thick and full of bubbles of gas fluid, which is an empyema. So for sure, ultrasound, it's better in terms of sensitivity than a CT scan for categorize the effusion. The last thing we are evaluating today is the pericardial effusion. As well, it's a virtual space, which is supposed to have no or really small amount of fluid. So we need to base our classical exam into inspection with the internal jugular enlargement, in the auscultation with muffled cardiac sounds, and the typical pericardial friction rub, which is not so common than we thought. The probe selection can be both the curvilinear probe or the phased array probe, which is actually better to evaluate it. The parameters as always, and we need to orientate the probe, depends on the view. We know the typical way to examine the heart from the subcostal view using the, like in this case, liver as an acoustic window to assess the subxiphoid, which is supposed to be the better view to assess pericardial effusion. In this view, this is the right ventricle, which is on top, left ventricle, right atrium, and left atrium. For assessing in the parasternal lung, we need to place the probe into the fourth left parasternal space with the marker towards the patient's right shoulder, orientated in the theoretical lung axis of the heart. And this is the typical image with the left atrium, mitral valve in the middle, left ventricle, ascending aorta, right ventricle on top, more anterior, and this is the descending aorta. What does an effusion look like? Like this. There's a lot of fluid around the heart. The heart actually is swinging inside the pericardial sac, but this is a really large effusion. Medical problems in terms of tamponade can occur even with really slow amounts of fluid, up to 100 milliliters. In parasternal lung, remember where the ascending aorta is, the descending aorta, and you are actually looking at the fluid between the heart and the descending aorta, which is a structure a little bit posterior to the left atrium. So that's all. Thank you. And every kind of suggestions, comments, don't hesitate to contact me